In this sketch, we'll be talking about conditions caused by the varicella-zoster virus, or VZV, including chickenpox, neonatal varicella, and shingles. After we briefly introduce each of these conditions, we will dive into each in more depth. Now, if you've read your classics, you know that Hera was not a big fan of Hercules, him being an illegitimate demigod love child between Zeus and one of his mistresses and all. Well, suffice it to say, Hera, Zeus's wife, had it out for Hercules from the beginning, from the neonatal days, in fact. But, as we'll soon see, with a little prophylaxis and passive immunity, feisty baby Hercules fought off every attacker Hera threw at him. Varicella-zoster virus, or VZV, is also known as human alpha herpes virus 3. It's one of the 8 herpes viruses known to infect humans. In sketchy mythology, VZV is represented by Zeus, the king of the gods and purveyor of rashes. Primary VZV infection causes varicella, more commonly known as chickenpox, which presents with a diffuse vesicular rash. The presentation, workup, and treatment of chickenpox will take place around Zeus's regal chicken. Neonatal varicella occurs when newborns contract VZV just before or shortly after birth and is represented by our inhumanly strong baby Hercules as he beats up bad guys to make his dad proud. It is important to know that this is a separate entity from congenital varicella syndrome, which occurs when the virus is vertically transmitted to the baby from the mother during the first 20 weeks of gestation and is considered one of the torch infections. Torch infections will be covered in a future course. Stay tuned. Reactivation of latent VZV causes herpes zoster, also known as shingles, which presents with a localized vesicular rash, typically in a dermatomal distribution. This presentation, workup, and treatment of herpes zoster will take place outside, next to the shingled outer wall, where a few beat-up bad dudes are trying to escape Hercules' wrath. With introductions out of the way, let's take a more in-depth look at each of these conditions, starting with everyone's favorite, inexplicably poultry-named disease, chickenpox, or varicella. While varicella can occur at any age, it most commonly occurs in preschool and school-aged kids, shown in our sketch by Eros, the preschool-aged winged cherub boy flying above Zeus. Due to successful vaccination efforts, varicella has become less common in recent years. Most of the patients you might see with varicella likely have not been immunized against it. Remember, the CDC's vaccination schedule recommends that children receive varicella immunizations at 1 and 4 years of age. The classic symptom of varicella is a generalized vesicular rash that is notoriously itchy, which is represented here by Zeus's bro, Poseidon, carrying a bouquet of roses with vesicular dewdrops on the petals, and Zeus itching away at his big bushy beard. Despite this, varicella will often initially present with a prodrome of fever and malaise, represented by the tired Hephaestus working away in his flaming forge, before going on to develop a pruritic macular rash on the trunk and face, which then spreads to the extremities. You can see this represented by Eros, showering Zeus in macular rose petals, which fall over his face and chest before continuing to fall over his arms and legs. These lesions will continue to evolve into papules, seen here as Artemis's bouquet of papular red flower buds, before ultimately becoming fluid-filled vesicles on an erythematous base, a stage that is described as dewdrops on a rose petal, and represented here by dewdrops on the rose petals of Poseidon's drippy bouquet. These vesicles will eventually become pustular and rupture, forming crusted papules, not unlike the dead crusted flowers held by the unamused Hades. Another hallmark of varicella is that lesions will appear in different crops, resulting in different areas of the body having lesions in different stages of development. This means that you will see the macules, papules, vesicles, pustules, and crusted lesions all at the same time in one patient. We represent this by having the floor littered with a mix of flower buds, petals with dewdrops, and crusty dead flowers. The varicella zoster virus is highly infectious, with transmission occurring through aerosolized droplets and contact with open lesions. Just think of Zeus's infectious laughter and the aerosolized droplets flying out of his mouth while he directly rubs the macular petals between his fingers. The virus also has a particularly long incubation period of around 14 days, represented by the half moon in the sky above Zeus. A person becomes infectious 2 days before the emergence of the vesicles and remains so until all of the lesions have fully crusted over. You can see this represented by the god of the underworld with his dead crusty flowers and how he lacks the infectious laughter that the other gods have caught. Also, new vesicles will typically stop forming within 4 days of onset, and with most lesions crusting over within 6 days. It is also important to know that you may see breakthrough infections in those that have already been vaccinated against varicella, although the clinical course in these patients is usually mild. This is depicted by our second Cupid flying by and taking aim with an intact syringe arrow. And this time, only a few macular petals are falling. No big deal. A common complication of varicella that you will need to keep an eye out for is secondary bacterial infections of the skin, including staph and strep, which are caused by scratching the lesions. This is represented by our fruit bowl with purple grapes arranged in a chain and cluster, kinda like chains and clusters of gram-positive cocci, the fruit of the gods. To learn more about these infections, check out our dedicated staph and strep skin infection sketch. With that out of the way, let's move on to the objective section. When you suspect a patient has varicella, you will need to complete a full skin exam that involves exposing all areas of the skin. This is so that you can identify and successfully treat all lesions, as well as to determine what stage they are in. You will also be looking for any signs of secondary bacterial infections caused by scratching, which will require additional treatment. This is depicted in our sketch by Aphrodite, goddess of love, beauty, and skin exams. While a diagnosis can usually be made based on the clinical appearance of the lesions, a VZV PCR can be used to obtain a definitive diagnosis by sampling fluid from ruptured vesicles. This is depicted by our recurring symbol for polymerase chain reaction, chains of polymers. You may also use a direct fluorescent antibody, aka DFA test, for a definitive diagnosis, and is represented by Aphrodite's fluorescent antibody crown. Vain much? Whenever you are considering a diagnosis of varicella, be sure to keep in mind other causes of childhood rashes. This includes measles, hand, foot, and mouth disease, disseminated HSV, and dermatitis herpetiformis. Feel free to check out the differential diagnosis menu for a more in-depth look. Once you have made a diagnosis of varicella, in immunocompetent children, treatment primarily consists of supportive care. See our forest nymph adjusting a pillow behind Zeus's back, including antihistamines for itching and acetaminophen for pain and fever relief. It's important to mention that these children should never be given aspirin due to the risk of Rye syndrome, depicted here by our No Peasants Allowed sign, with ASA capitalized. That's no to ASA. It would also be a good idea to clip all of the fingernails to limit the amount of skin breakdown from itching, which will reduce the risk of secondary bacterial infections. For children less than 12 years old, varicella is usually self-limited and does not require treatment with antivirals, depicted in our sketch by our Happily Ever After banner flying at the peak of Mount Olympus. In children that are at an increased risk of complications, such as the immunocompromised or the unvaccinated who are 13 or older, you should consider treatment with IV or PO acyclovir, as it can reduce illness severity and complications if started early enough. Notice that this guard here is using a crutch, our recurring symbol for immunocompromised states. There is also a broken syringe arrow, which represents unvaccinated patients, with the 13-shaped axe on his back indicating unvaccinated patients that are 13 and older. And finally, his shield bears our symbol for acyclovir, a recycling logo with an A. Hey, just because he's an orc doesn't mean he doesn't want to save the planet. He's not a monster. Any unvaccinated child who has been exposed to varicella but has yet to develop signs of active infection should be given the varicella vaccine as soon as possible, optimally within 5 days of exposure. This can prevent or modify the illness. This includes children who have only received their first dose of varicella vaccine. Give them that second one. That V on his chest represents 5 days, and that syringe sword is our recurring symbol for vaccination. Patients who present to clinic after 5 days of exposure can be monitored for development of disease, at which point standard treatment can be initiated. You may also give varicella zoster immune globulin to children with known exposure to varicella who are ineligible for the varicella vaccine and at high risk of complications. This includes immunocompromised patients and premature infants less than 28 weeks. Immune globulin, which confers so-called passive immunity, is symbolized by the stash of protective antibody arrows. And again, we've added an immunocompromised crutch. Lastly, given how infectious varicella is, you will need to exclude infected children from school and daycare until at least all lesions have crusted over, at which time they may return. This is depicted by the quarantine velvet rope in front of the infectious laughing gods. Remember that these ethereal beings represent stages when the lesions are still infectious. Crusty Hades, on the other hand, represents the stage when the lesions have completely crusted over. Time to head back to school. Next up, we'll be talking about neonatal varicella, which is also known as perinatal varicella. Remember, neonatal varicella is a separate entity from congenital varicella syndrome. While neonatal varicella is contracted just prior to or shortly after birth, congenital varicella syndrome is caused by the vertical transmission of the virus from the mother to the baby in the first 20 weeks of gestation. With that out of the way, let's take a look at neonatal varicella. Depending on the time of infection, neonatal varicella may have a mild or more severe course. Specifically, when the mother contracts the varicella zoster virus from 28 weeks of gestation to 5 days before delivery, infants are generally protected from severe varicella by maternal IgG antibodies, hence the antibody pattern adorning this pregnant mom here, as well as the 28-week band in her hair. An oddly specific fashion statement. In contrast to this, when the mother contracts the virus from 5 days before to 2 days after delivery, infants are at high risk of complications, as they will contract the virus but not be protected by maternal antibodies, which take time to develop. This is represented by this sad bear sitting in a crib marked -5 to +2. Cases are often milder in infants that are exposed to the virus 10 to 28 days after delivery, although they are still at higher risk of complications compared to older infants or children with varicella. This is depicted by this sad girl next to the crib who has some pink dots on her dress, which, compared to that sad bear over there, actually doesn't look that bad. The classic presentation of neonatal varicella is the development of a fever within the first few days after birth, represented by baby Hercules' Nemean flame bandana. This is followed by the eruption of the characteristic generalized vesicular rash. In uncomplicated cases, neonatal varicella will progress similarly to how chickenpox progresses in older children. Specifically, the rash will start as macules before rapidly progressing to papules, then vesicles, and finally crusting over. The rash will typically first appear on the head before spreading into a generalized body rash, with lesions in various stages of development and healing. Because these infants have immature immune systems, they are at greater risk of developing disseminated varicella compared to older children. This can present as varicella pneumonia, which is the leading cause of death in neonatal varicella. Disseminated varicella can also present with hepatitis or meningoencephalitis. Needless to say, neonatal varicella can be quite serious, with a mortality rate of up to 30%. When it comes time to examine the little guy or girl you suspect has neonatal varicella, you will need to completely expose all areas of the skin for a thorough exam. Beyond a skin exam, you will also need to carry out a full abdominal and lung exams to look for signs of hepatitis or pneumonia. In order to assess for meningoencephalitis, evaluate their overall behavior, Look for any focal neurological symptoms and check the primitive reflexes such as rooting and Moro reflexes. You can see all these steps symbolized on that shelf of exams in the back, which will hopefully help you on your shelf exams. To confirm a diagnosis, you will need to detect the virus through the use of PCR, which has both high sensitivity and specificity. Recall that PCR is represented by the multicolored chains adorning Aphrodite. PCR can detect the virus from swabs or scrapings of vesicles, from scabs of crusted lesions, from tissues obtained by biopsy, and even from cerebrospinal fluid in cases of suspected meningoencephalitis. You may also use direct fluorescent antibody testing depicted by Aphrodite's antibody crown, which can provide a rapid diagnosis, but should not be used in place of PCR, as it is less sensitive. It's also important to obtain imaging quickly if you are concerned for some of the more severe complications that can occur. Specifically, brain imaging is essential in cases of suspected encephalitis to rule out other possible causes of symptoms, such as an infarction or hemorrhage. If you suspect VZV pneumonia, you should consider obtaining a chest X-ray. Notice that we've drawn in our recurring MRI magnet, CT scan cat, and chest X-ray crossbone symbol. While working up a child with suspected neonatal varicella, be sure to keep in mind other causes of rashes in infants. This includes benign vesiculopustular eruptions, miliaria, neonatal HSV, and hand, foot, and mouth disease. Check out the differential diagnosis menu for a more in-depth look at these and several other conditions. Neonates born to mothers with symptoms of varicella 5 days before to 2 days after delivery, which is that sensitive window we mentioned earlier, you will need to give the little guy varicella zoster immune globulin post-exposure prophylaxis, which may prevent infection or lessen the severity of the disease. In cases with a confirmed diagnosis of neonatal varicella, you will need to start them on IV acyclovir ASAP to reduce the risk of life-threatening complications. In addition to medical treatments, it is recommended that newborns exposed to or infected with varicella should breastfeed, as antibodies in breast milk may be protective. This is depicted by the statue of the twins Remus and Romulus breastfeeding from a she-wolf. Yes, they're Roman, not Greek, but what's a few hundred years here or there? Heracles, Hercules, tomato, tomato. Lastly, you will need to initiate infection control measures that include both airborne and contact precautions to prevent the spread of varicella to other infants and mothers. Additionally, mothers with active VZV must be isolated from their newborns until they are not infectious, and infants who develop varicella should be isolated from other infants. All right, time to wrap up the sketch with herpes zoster, also known as shingles, the details of which will be illustrated in the backyard near this shingled wall. Shingles occurs as a result of the reactivation of latent varicella zoster virus that has been lying dormant in the dorsal root ganglia following a primary infection. Hence the little fella here, who's rudely awoken during his nap on those dorsal tree roots. While herpes zoster typically occurs in the elderly and is rare in healthy children, it does occur in immunocompromised children, such as those with an active HIV infection. So this fleeing dude here is carrying our immunocompromised crutch symbol. Children are also at a higher risk of developing herpes zoster if they have a history of early exposure to varicella. This includes congenital varicella syndrome, neonatal varicella, or patients who contracted varicella before 2 years of age. The defining presentation of herpes zoster is the emergence of a unilateral vesicular rash in a dermatomal distribution, specifically in a single dermatome or in several contiguous dermatomes, which correspond to the sensory field of the infected dorsal root ganglion. Although it can occur in any dermatome, it is most commonly seen in the thoracic and lumbar dermatomes, as depicted by Demeter, goddess of harvest, law, and dermatomes. Similar to the evolution we covered with varicella, the rash of herpes zoster begins as a maculopapular eruption that gradually evolves over several days into vesicles and blisters before eventually becoming pustular. This is followed by the crusting over of lesions within about a week, at which time lesions are no longer considered infectious. After these lesions have healed, you should expect to see persistent scarring and hypo or hyperpigmentation, which can last months or even years. You should also be aware that if you continue to see new lesions appear more than a week after initial presentation, an underlying immunodeficiency may be present, which needs to be evaluated. The rash of herpes zoster is typically associated with acute neuritis, and which is often described as deep burning, throbbing, or stabbing pain. Prodromal pain may even occur in the dermatomal area 2 to 3 days before the appearance of the rash. This is depicted by our unfortunate fellow getting stabbed in the side with one of Zeus's lightning bolts right before he can escape over the shingles. Acute neuritis can last for 30 days or more, but it is important to note that this is different from postherpetic neuralgia. Speaking of which, you see that lightning storm approaching? While herpes zoster will generally have a milder clinical course in children than in adults, there is still a concern for complications, including postherpetic neuralgia. This is defined as pain persisting for several months after the onset of rash and may include sensory symptoms such as numbness, dysesthesias, and increased sensitivity. Lightning-y, if you will. Another rare but possible complication that you will need to be aware of is visceral dissemination, particularly in the immunocompromised, such as those with AIDS or leukemia. So we've added a shower of petals around our immunocompromised fella. Lastly, you should be on the lookout for any secondary bacterial infections, such as strep or staph, that can complicate herpes zoster lesions and is represented again by the chains and clusters of purple grapes. When it comes time to examine the little guy or girl you suspect has herpes zoster, you will need to complete a full skin exam to identify the area of involvement, all while wearing gloves to avoid accidental transmission. This is important, as herpes zoster will most often be unilateral and confined to a single dermatomal distribution, or several contiguous dermatomes, which can greatly help you in limiting your differential. As we mentioned earlier, you can expect to see lesions primarily in the thoracolumbar dermatomes, which correspond to the sensory fields of the infected ganglion. While you can usually make a diagnosis of herpes zoster in healthy children based on clinical features, the presentation may be altered in those that are immunocompromised. If a definitive diagnosis is needed, perform PCR on the fluid from the vesicles, just like you would in varicella or neonatal varicella. You may also choose to use direct fluorescent antibody testing for a more rapid diagnosis, seen here as Aphrodite's antibody crown, but this should not be used in place of PCR, as it is less sensitive. During your evaluation of a child with suspected shingles, be sure to keep in mind other causes of localized vesicular rashes in children. This includes herpes simplex virus infections, impetigo, contact dermatitis, and dermatitis herpetiformis associated with celiac disease. Check out the differential diagnosis menu for a more in-depth look. Once you have made the diagnosis, they should be started on antiviral therapy with oral acyclovir, or in more severe cases, with IV acyclovir, preferably within 72 hours of symptom onset, hence the 3 suns on his shield. This will help to lessen the severity and duration of pain, promote the healing of the skin lesions, and prevent new lesions from forming. Typically, antiviral therapy is only given after 72 hours if new lesions are still appearing, as there is likely little benefit once lesions have crusted over. While the efficacy of antivirals for herpes zoster in patients less than 50 years of age has not been well studied, the associated risk is very low, so treatment is considered a worthwhile option. The exception to this is in immunocompromised patients, in whom rapid initiation of IV acyclovir is vital, even if they present after 72 hours. This is because they are at a greater risk of severe complications, such as disseminated zoster. For all patients, consider supportive measures, including acetaminophen, for their pain. In addition to treatment, infection control measures should be put in place to prevent the unnecessary spread of infection. This means that immunocompetent children should be placed on contact precautions and have their lesions covered or wrapped in gauze. Children whose lesions have all crusted or been covered may also return to school. The last thing you should know is that immunocompromised children with herpes zoster may transmit the virus through both direct contact and respiratory secretions, unlike immunocompetent hosts that can only transmit the virus through direct contact with vesicular lesions. This means that immunocompromised children with shingles need to be placed on airborne and contact precautions and excluded from school. All right, let's wrap up this sketch with a brief review of what we've learned. The three conditions caused by the varicella-zoster virus are varicella, or chickenpox, which is the primary infection of the virus, neonatal varicella, which is when the virus is contracted just before or shortly after birth, and herpes zoster, or shingles, which is the reactivation of latent virus. Varicella usually occurs in childhood, particularly in those that have not been vaccinated, and is characterized by a prodrome of fever and malaise and the emergence of a diffuse, itchy vesicular rash. This rash typically begins as an itchy macular rash on the trunk and face, which spreads to the extremities before evolving into papules, followed by the characteristic vesicles with an erythematous base. Eventually, these vesicles will become pustular and rupture, leaving behind crusted papules. As these lesions will appear in different crops, you should expect to see lesions in different stages of development on different areas of the body. Of special note is that an infected child will first become contagious 2 weeks before the emergence of the rash. This, in addition to the highly contagious nature of the virus, which spreads via aerosolized droplets and contact with open lesions, makes it very difficult to control without widespread vaccination. Breakthrough infections may occasionally occur when only one dose of vaccine has been received. However, the clinical course is usually mild. The most common complication to be aware of is secondary bacterial infections with staph or strep, which are caused by scratching of the lesions. While you will usually be able to make a diagnosis by the appearance of the lesions, a definitive diagnosis can be made with a VZV PCR or direct fluorescent antibody test. Once a diagnosis has been made, treatment primarily consists of supportive care, as varicella is usually self-limited in most children. These measures include antihistamines for itching, acetaminophen for pain and fever relief, and clipping fingernails to limit skin breakdown from itching. As a quick aside, it is important to remember that these children should never be given aspirin due to the risk of Rye syndrome. Children at risk for complications such as the immunocompromised or unvaccinated teenagers may be treated with oral or IV acyclovir. The varicella vaccine should be given as soon as possible, optimally within 5 days, to all unvaccinated children who have been exposed. Children who have only received the first dose should get a second. Varicella zoster immune globulin may be given to children with a known exposure to varicella who are ineligible for varicella vaccine and at high risk of complications. Lastly, given its highly infectious nature, all infected children should be excluded from school and daycare until all their lesions have crusted over. Neonatal varicella occurs when the varicella virus is contracted just prior to or shortly after birth. When contracts the virus between 28 weeks gestation to 5 days before delivery, infants are protected by maternal IgG antibodies. When the virus is contracted from 5 days before to 2 days after delivery, infants are not protected by maternal antibodies. This results in more severe disease. Infants exposed to varicella virus 10 to 28 days after delivery may develop a milder form of neonatal varicella. Neonatal varicella typically presents with a fever developing within the first few days after birth, followed by the eruption of a generalized vesicular rash. Most cases progress similarly to varicella in older children. Unlike chickenpox, there are various severe complications that can occur given the immature immune systems of these babies. This includes varicella pneumonia, which is the leading cause of death in these infants, as well as hepatitis and meningoencephalitis. To make a definitive diagnosis, you will need to be able to identify the virus with either a PCR or a direct fluorescent antibody test. While imaging is often unnecessary in these cases, if you have any suspicion for complications, such as meningoencephalitis or pneumonia, you will need to act quickly in getting a brain MRI or CT or chest X-ray, respectively. If you suspect a neonate was exposed to varicella, they should be given varicella zoster immune globulin, as this may prevent infection or lessen its severity. Alternatively, when a diagnosis has been confirmed, they should be started on IV acyclovir ASAP to reduce the risk of life-threatening complications. In addition to this, these babies should be breastfed, as their mother's antibodies in breast milk is protective. Infection control measures that include both airborne and contact precautions should be put into place to limit its spread. Herpes zoster, aka shingles, occurs as the result of reactivation of latent varicella zoster virus in the dorsal root ganglia, where it took up residence following a primary infection of the varicella zoster virus. In children, it is seen in immunocompromised children and in those that have a history of early exposure to the virus. Herpes zoster is characterized by the emergence of a one-sided vesicular rash in a dermatomal distribution. This corresponds to the sensory field of the infected dorsal root ganglion and primarily affects the thoracic and lumbar dermatomes. It will typically initially present with localized symptoms of acute neuritis before emerging as a maculopapular rash. Shingles will typically have a milder course in children than in adults. However, complications can still occur, including secondary bacterial infections as well as postherpetic neuralgia. Much less common, but more dangerous, visceral dissemination can occur in those that are immunocompromised, such as those with AIDS or leukemia. Once a diagnosis has been made, they should be treated with oral acyclovir, preferably within 72 hours of symptoms appearing to maximize its effects. In immunocompromised patients, the rapid start of IV acyclovir is especially vital due to their greater risk of severe complications, including disseminated zoster. In immunocompetent children, only contact precautions are required, such as wrapping lesions in gauze. However, immunocompromised children can also transmit the virus via respiratory secretions, meaning that both contact and airborne precautions are required, including exclusion from school. Well, the mythology gets a little boring at this point. Hercules grows up, performs 10 labors, which were more like 10 odd jobs, one involving cleaning stables, and another involving the retrieval of a girdle of some kind. So let's keep it PG-13 and leave it at that, shall we?